First case is a female of 25 years old who comes to the ED on Thanksgiving accusing of pain in her abdomen since her last meal 4 hours ago. She vomited on the way to the hospital. Her blood pressure is 120/80. She has 75 beats per minute as a blood pulse and 38 degrees Celsius. On palpation of the right upper quadrant, there is an inspiratory arrest on ERCP to administer IV fluids and antibiotics, to perform a cholecystectomy, or to perform a HIDA scan. Let's go to the second question. So the patient is stabilized, and in the next 72 hours she develops jaundice, right upper quadrant pain, and fever. What is the most likely diagnosis with the new presentation? Acute cholecystitis, choledocholithiasis, or cholangitis? The first one was a HIDA scan, D. The second one was, as Talha said, cholangitis. Now, the patient presents with findings indicative for acute cholecystitis in the first part. When the ultrasound is not able to discern the stone, the HIDA scan is the next indication for a diagnostic test. The radio tracer will not enhance the gallbladder in the case of acute cholecystitis. The important point about these two questions is comparing acute cholecystitis with choledocholithiasis and with cholangitis. By definition, an acute cholecystitis is an inflammation of the gallbladder. Usually it is caused by gallstones. In comparison, choledocholithiasis is the obstruction of common bile duct, which can also be frequently caused by gallstones. Another instance for choledocholithiasis could be represented by strictures. Finally, cholangitis is the infection of the common bile duct. This can happen secondary to gallstones. On history and presentation, the acute cholecystitis has the Murphy sign, meaning that when the patient breathes in and the right upper quadrant is touched, the inspiration will halt. Also, the patient has right upper quadrant pain, she comes with low fever, and we have nausea and vomiting. On the other hand, choledocholithiasis is a condition that comes with a biliary colic but has jaundice because the obstructed bilirubin will go into the blood flow, thus leading to bilirubin deposition inside the skin. And an important aspect of choledocholithiasis is that it can be with or without fever. The last one, cholangitis, has specific presentation, namely the Charcot triad, a right upper quadrant pain, fever, and jaundice. And it can also associate septic shock and altered mental status, leading to the Raynaud pentad. How do we diagnose each entity? Acute cholecystitis is diagnosed initially with ultrasound. If the ultrasound is equivocal, then we go for the HIDA scan, as we did in the previous question. On the other hand, for choledocholithiasis, we do not do only the ultrasound, but we do some lab work, namely we go with direct bilirubin and we see an increase in alkaline phosphatase. The important aspect of cholangitis on the lab work is the fact that it is an infection. Therefore, it will lead to leukocytosis and we will have positive blood cultures. We will also find an increase in direct bilirubin and alkaline phosphatase as cholestatic markers. The treatment for acute cholecystitis is represented initially by IV fluids and antibiotics. Once the patient has been stabilized, usually at 72 hours, then cholecystectomy is performed to avoid future crisis. Choledocholithiasis, on the other hand, as we explained previously, is treated with ERCP. And then cholecystectomy is applied to the patient. In the case of cholangitis, being an infection that leads to septic shock, not only that we give IV antibiotics, but we also admit to the ICU. The moment we have a Raynaud's pentad, we pursue to percutaneous cholecystectomy or ERCP without waiting for the patient to be stabilized due to the emergent nature and the life-threatening situation.